We've all seen news stories like these. They tell us about life-preserving medications, new drugs, and equipment that are said to predict cancer or improve the quality of life for people living with a serious illness. But news stories also remind us of the high cost of paying for new treatments and equipment. Sometimes the decision to spend money on one new treatment may mean that there isn't enough money left over to spend on another treatment or service. In Canada, healthcare budgets have grown steadily in recent decades, now consuming close to half of all expenditures in some jurisdictions. Resources is not the only tough choice we face. Sometimes a new cancer drug is not funded because its value to patients is not yet proven, or a new treatment may not be paid for because its health benefit is so small. In that case, the money could be used for something else, like more hospital beds, or towards new strategies for smoking cessation. Tough choices like this are often in the news. Take the recent example of an experimental treatment to help patients with multiple sclerosis. It's a procedure known as liberation therapy. Canada has one of the highest rates of multiple sclerosis in the world, and news of this new procedure is inspiring hope among patients for a better quality of life. The treatment, however, is not approved in Canada because it has not met a sufficient standard of evidence. Canadians wanting the procedure must travel outside the country at their own expense to get it. Understandably, those who suffer from MS want answers to why this is the case. Another recent controversy in the headlines involves the routine use of mammography to screen women for breast cancer. In November 2009, the United States Preventive Services Task Force recommended against automatic routine screening mammography in women aged 40 to 49. Instead, women should receive mammograms every 2 years after age 50. The task force, made up of independent medical experts and scientists, concluded that the extra health benefit with earlier screening is fairly small. They also cautioned that moderate harms from screening, like overdiagnosis and unneeded biopsies, remain at any age. The task force recommendation was received positively by some groups in the U.S. The National Breast Cancer Coalition, for example, saw it as a decision based on objective science, while recognizing the need for more studies. However, it was greeted with skepticism by the American Cancer Society, which recommends annual screenings beginning at age 40. Protests also came from U.S. politicians, who saw the recommendation as a form of rationing or denying treatment to women. Strong concerns were also voiced by breast cancer survivors who believe they owe their survival to early detection. In Canada, the debate has been vigorous too. In some provinces, regular screening begins at age 40 and at age 50 in others. In 2011, the Canadian Task Force on Preventive Healthcare released guidelines for breast cancer screening that align with those of the U.S. Task Force's recommendations, suggesting that women aged 50 to 74 receive routine mammograms every 2 to 3 years. This has led Canadian provinces to review their breast cancer screening protocols. The debate about the benefits and harms of mammography is also a debate about our social values and limited resources. These headline stories show that healthcare funding decisions can be complicated, and a deadline-driven, 24-hour media environment doesn't help simplify things. We can help minimize controversy if we strive to make decisions that are as fair as possible and based on the best information we have. This will help set priorities more clearly when it comes to spending Canada's limited healthcare resources. And while there will always be challenges in making healthcare funding decisions, knowing how those decisions are made and why will help prepare you as a participant in the process.